Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh. Welcome to another Libyan Cardiac Society session, Arrhythmias for Clinician Tips and Tricks. Our speaker today, Dr. Fathi Idris from Nashville, Tennessee, interventional cardiologist and electrophysiologist. On the expert panel, we have two electrophysiologists, Dr. Yusuf Al-Darrat from Kentucky and Dr. Khalid Bouzguiya from Marshall University, West Virginia. Before we start our session, we have Dr. Hawad Derby, consultant family physician. Dr. Hawa is the head of Libyan Cardiac Society Hypertension Working Group. حتعطينا إن شاء الله مقدمة بخصوص الحملة الوطنية لارتفاع ضغط الدم قبل بداية المحاضرة. دكتور حوا.
السلام عليكم ورحمة الله وبركاته. إن شاء الله الجميع بخير. إن شاء الله مع المركز الوطني جمعية القلب الوركينج جروب اوف هايبرتنشن بنديروا حملة وطنية لمكافحة مرض ارتفاع ضغط الدم عن طريق حملة توعوية وبنديروا مسح طبي معها اللي هو هايبرتنشن سكرين. كل الهدف إن بنرفع مستوى التوعية بالوقاية والتشخيص والعلاج، ونحفزوا الأفراد على قياس ضغط الدم ومعرفة مستوى السكر والدهون ومعدل الاختطار، الوزن، ونحسب البادي ماس اندكس. المستهدفين طبعا جميع البالغين، يعني أي حد فوق 18 سنة يقدر معناها نقيسوا له ضغطه. المكان كل المدن من ليبيا مستهدفة. الحملة إن شاء الله حتنقسم إلى حملة إعلامية كلها فيها توعية، يعني عن طريق سواء صفحات التواصل الاجتماعي، عن طريق الإذاعات. حتنطلق الحملة إن شاء الله يوم 14/5، وبالنسبة للمسح حيكون يوم 17/5 إلى 17/6، يعني حيمتد إلى شهر كامل. أي شخص يعني من مجموعات اللي عنده رغبة أنه يشترك في الحملة يقدر يتواصل معنا. إن شاء الله المركز الوطني حيوفر الأجهزة نتاع الضغط، يعني حتكون إلكترونية، أجهزة قياس السكر والباقي الأجهزة اللي هي المطلوبة. التفاصيل إن شاء الله في بكرة اجتماع على الزوم نفس الشيء، يعني نقولوا التفاصيل بالنسبة للمجموعات وين يقدروا يقيسوا الضغط، كل مجموعة إنها كيف تكون مجموعة وين هي ترغب إنها تقوم بالحملة نتاعها. نتمنى يعني من الجميع المشاركة، هذا عمل وطني، والوقاية طبعا لها دور أساسي في منع الأمراض، أمراض القلب بالخصوص والهايبرتنشن بصفة عامة والهايبرتنشن بصفة خاصة. شكرا لكم وإن شاء الله بالتوفيق.
شكرا دكتورة حواء، أتفق معك تماما. كيف ما نعرف احنا من صغرنا الوقاية خير من العلاج، فهذه من أهم المشاريع اللي تقدموها للدولة الليبية، خاصة والله أي مشروع يتقدم في حول العالم، يعني هي البرايمري بريفنشن. فالآن نبدأ في محاضرتنا. دكتور فتحي، the stage is yours now.
شكرا منصور، شكرا دكتور حواء، شكرا أيمن وباقي الزملاء في مجموعة القلب الليبية على إتاحة الفرصة to present for this general rounds. So I have no interest, I have no conflict interest to regard to this presentation. Let me see my 1 second. And so the whole thing about this presentation is not to, we're not going to go through detailed EKG. The whole concept, the purpose of this presentation is to give the general clinician who are not specifically arrhythmia trained some tools, some things to use to help reach the diagnosis, especially in complex rhythm situations. So I'm not going to give you specific details, but we're going to go with general concepts. So there are three basic concepts. I find them very useful when you look at rhythm diagnosis. First one, a rhythm diagnosis is quantitative, not qualitative. In other words, the arrhythmia either exists or do not exist. There's nothing called mild atrial fibrillation or some VT. You can say patient is mildly anemic, maybe but you cannot say AF is patient has mild AF or moderate AF or some VT. So it's completely quantitative. It exists or do not exist. So that's a very important concept for rhythm diagnosis. Second thing, rhythm diagnosis precision is so crucial, and to be precise in getting your diagnosis, you have to delineate P wave versus QRS complex. And this is probably the core idea is try always to find where is the P wave, where is the curious complex, and what's the relationship between them. So that's a very important second concept. Thirdly, when you do the 12-lead EKG or rhythm strip, they have their own limitations. So sometimes, even with a good tracing EKG, the diagnosis is still not clear, even in the best hands, even in the most expert arrhythmia specialists. So in which case, you need to do something else. You need to do sometimes maneuvers to delineate what's an underlying rhythm. Sometimes you need to give drug. And sometimes it's impossible until you have intracardiac tracings, like either you take the patient to the EP lab or you do a pacemaker interrogation. And we're going to go over these concepts throughout the rest of the presentation. So these are the three main concepts we're going to go through. Let's see. So we're going to start by a case. And then for this one, I want to get the input or the opinion of the audience about this, and then we will revise this case later on. So this is a 43-year-old female. She had history of ischemic cardiomyopathy. She had an ICD implanted. So she presented with a shock by her device. So they did a device interrogation. I know this is a little bit complex, but I'll explain to you. This is a tracings from her ICD, and the tracings show VF, VF, etc. So this is the tracing. So this is the rhythm, the patient's rhythm. The arrows you see here are the markers. So the device tried to label each beat it sees. You see sometimes the device missed some beats. So this beat was not seen by the device, but this beat. Do you guys see my my arrow, Mansour?
Yeah, very, very clear, Dr. Fathi. Yes.
Okay, good. Good. So you see the device sometimes misses some of those beats. This beat is completely missed. Sorry, that's going to go bad for some reason. I keep clicking. So the question in this case, is this patient in sinus rhythm? Yes, no, maybe. So is this patient in sinus rhythm? Mansour, I don't know whether we have polls or we just go by.
I thought about the polls honestly earlier, but
okay, yeah, good. So maybe in the chat, right? We'll take time exactly. So maybe in the chat, everybody enter 1, 2, or 3. Yes, 1. If you think this patient is in sinus rhythm, put 1. If you think the patient is not in sinus rhythm, put 2. If it may be, put 3. So yeah. So
can
we
I
see some
give them a
responses.
hint? And this question is tricky. Just let you know, give you a hint. Trying to help.
Okay, no. Okay, no, we don't need to go to you know, I think we want to get the input about this. So I think few twos. There's maybe a couple of people think the patient is in sinus rhythm. Okay, we'll come to this case later on. So let's go with the tip number 1. Always think about A and V. Okay, think atrium and ventricle. Most of the time, the atrium drives the ventricle. So A precedes B. That's what in a common rhythm, normal sinus rhythm. In atrial fibrillation, atrium typically drives the ventricle and SVT. So there are situations where A drives the V. There's other rare situations where the ventricle drives the atrium. Believe it or not, the ventricle can get control of the atrium if the patient has ventricular tachycardia. So some ventricular tachycardia, the situation is reversed. So the ventricle drives the atrium and take control of the atrium. Not common, but possible. Okay, so that's the second scenario. Or the atrium and the ventricle can be completely unrelated. For example, in patient with complete heart block, this is a common famous AV dissociation. And in some ventricular tachycardia or ventricular fibrillation, patient may have no VA relationship. And then you may ask me, okay, how come we have VT here and here? Well, in ventricular tachycardia, it depends on the status of the AV node and the hyperconductive system and the whole conductive system. The ventricle may be successful in transmitting back the electricity and capture the atrium, in which case V drives the A. But if the VA conduction gets interrupted by anything, and then you probably end up in the VT situations. And the reason to think about this, if you see AV dissociation, usually the diagnosis is quite simple on 12-lead EKG because you will be able to discern, you'll be able to see where are the P waves, and hence you can tell where is the tachycardia. But if the patient's ventricle capture the HM all the time, all these P wave will be hidden and maybe impossible to see them. So think about this concept. So normally HM drives ventricle, but rarely ventricle may drive the HM in certain VTs, or the HM and ventricle are dissociated, okay? So let's go to, so this is we're gonna go over a basic, simple, what we call intracardiac electrogram. And because this will help simplify the concepts we're gonna talk about. For people trained in rhythm, electrophysiologists, and people dealing with pacemaker, this is a common tracings. So we have two channels. The channel at the top is in the atrium. The channel at the bottom is in the ventricle. The paper speed is the same paper speed as the EKG. So it's 25 paper speed. Every small complex is about 4 milliseconds, and every large complex is 200 milliseconds. What you see here, what we call near field electrogram, it's narrow. It's not like your surface EKG. This is all you see is a sharp inflection like this, very sharp inflection. You see it in the atrium, and here you see it in the ventricle. So try not to read this as a EKG, like surface EKG, like don't see, this is ST elevation. No, this is not an ST elevation. So this is what we call near field electrocardiogram. And the idea of this is only timing, okay? So the idea of these tracings is not to give you any bundle branch block or whatever. It's mainly to show you the timing. And the timing actually for this tracing goes from left to right. So here, if you look at the timing here, the atrium event happened. And then after that, the ventricle event happened. And after this atrium event, second ventricular event happened. And you can, you can tell here that the atrium is driving the ventricle. So the A precedes the V. There's A before each V. So this is a beautiful normal sinus rhythm taken from a patient's pacemaker, okay? So this is pacemaker. The atrial lead shows the patient has its own rhythm, and the ventricle follow that. So this is what we call atrial driving the ventricle, okay? So that's a normal. So we're gonna use this example to understand some of those arrhythmia tracings, okay? Next, so this is a 90-year-old female. She's in the hospital, and she present on the telemetry. She had this run of wide complex tachycardia. As you can see here, there's 3 channels: channel 1, channel 2, channel 3, and she had kind of sinus beat. And then, sorry, I just need to. For some reason, my marker keep running. So the sinus beat. And this QRS complex is relatively narrow, so second sinus beat, and then there is PR interval slightly long, and then after that you see a run of wide complex tachycardia. The machine called it ventricular run, means ventricular tachycardia, and label it as ventricular tachycardia, as you can see, the square like black boxes here. So this was labeled as ventricular tachycardia by the machine, and looks wide and ugly. And then later on, you can see the patient has another beat at the bottom here of the same thing. And if wide QRS complex, that's faster than the normal rhythm. So it's wide and tachycardia. So wide complex tachycardia, is this ventricular tachycardia? Well, if you need to get some more information. So if you zoom on this run of tachycardia, and if you look carefully, you can see some little P waves preceding each QRS complex. So there's a P, which was not existing in this T wave here. After this beat, there is a P, led to this QRS complex, another P, and there's a clear P wave preceding each of these QRS complexes. And this is very suggestive that what we see here is a run of atrial tachycardia, because started in the atrium somewhere, and that was associated with some ventricular conduction delay or aberration or whatever it is. So in this case, A drives the V. It's not the other way around. Well, rarely you can have atrial tachycardia and ventricular tachycardia start at the same rate, but that's going to be impossible, right? It's too much of a chance that the atrium tachycardia and ventricular tachycardia starts at the same rate all of a sudden. So this is almost diagnostic that whatever the machine called it ventricular tachycardia is nothing but just an atrial tachycardia, because we applied the simple rule. Do we see a P wave? We did. So let me just go back for some reason. Sorry about that. For some reason, my mouse keep moving to the next slide. So there's a P wave preceding each Keras complex, or A drives the V, and it's very consistent. So you see it here. Okay, so this is a case where you can 100% say, well, this is an atrial tachycardia. I don't care how wide this Keras complex. This is not ventricular tachycardia. Just applying the same rule. Who drives who? A drives V, not V drives A. Okay, so there's the intracardiac tracing. So this is when we go back to those tracings, you see the A before the V. So this patient has a sinus rhythm, A before V, A before V. So this is 2 sinus beats, okay? And then the next sinus beat should be somewhere there, but the next beat came early. So that A and drive V, A drives V, and every A was followed by V until the tachycardia terminated here. And then after that, sinus rhythm came back again. So what we see in here, this is exactly the rhythm strip I showed you earlier, the wide complex tachycardia labeled as VT. But when you apply the intracardiac concept or intracardiac tracing, you can tell this is exactly what you see. You see a run of atrial tachycardia, not ventricular tachycardia. Let me take this case now. This is another patient, and this is the intracardiac EGM. Okay, so what's the diagnosis here? You have, I want you to write either one of them, VT or AT. Just type in the chat box, either AT or VT, just 2 letters. Okay, well, for some reason moving. Can people type in the chat box AT? Okay, yeah, somebody type AT. VA, VT, AT. Okay. So for AT, the atrium has to drive the ventricle. This is the AT. So the AT, what you see, the atrium starts and the ventricular follow. The atrial start and ventricular follow. And when the atrium finish, no ventricular follow. So if this is a VT, if this is a VT, some other beat would be here. So this is the past one was AT. Now the one I showed you after, this is the one in question. What you see here, sinus rhythm, A drives V, A drives V, A drives V until this point. But from this point, what we see, the earliest beat is in the ventricle. Remember, the bottom one is the ventricle. So the ventricle started and then was faster than the atrium. So we have many ventricular beats, but the atrium was going uninterrupted. You see the atrium is simply maybe slowed down a little bit, but the atrium going at its own rate. So what we see here, we see VA dissociation. So the ventricle goes fast, and the ventricle goes faster than the atrium, independent than the atrium. So we have a run 1, 2, 3, 4, 5, 6, 7, 8. We have a run of 8 beats of ventricular tachycardia, while the atrium was going nicely in sinus rhythm, doesn't care about what's happening in the ventricle. And then after the ventricular tachycardia decided to stop, the atrium took over again. Now the atrium drives the ventricle, the atrium drives the ventricle, and the atrium drives the ventricle, and so on and so forth. So this is a nice example, shows where there's VA dissociation. So sinus rhythm continue on the top channel uninterrupted. The ventricle has a run of ventricular tachycardia for 8 beats, and then the ventricle tachycardia stopped and the sinus node took over again. Okay, I know this is probably a little bit different concept from what we do with 12-lead EKG, but these important concepts, if you try to entertain them, it will help you understand what you see on the surface EKG in day in and day out cases. So the tip number 2, then what you do, I want you to search for the P wave, search carefully for the P waves. And here's where areas you can search for the P wave. The P wave can be hidden in the Keras complex, in which case you cannot see it. The P wave can be hidden in the ST segment or on the T wave. So search carefully for the P P wave. I recommend that you look at these two leads very carefully, lead 2 and lead V1. I love lead V1. V1 is probably a treasure box. It has a lot of information, and sometimes the P wave cannot be seen only if you use lead V1. So you have to be careful to look at lead V1. Sometimes you cannot find the P wave until you do a pacemaker interrogation, like in the last two cases I showed you. You do a pacemaker interrogation when the patient has the arrhythmia, and it tells you exactly where's the P and where's the V, and then you can tell what's the exact diagnosis. This is VT or AFib or whatever it is, but that sometimes you need to do that. And rarely you do something called esophageal lead. It's an old technique, but still sometimes can be used. So we're gonna go over these little bit tips here in the next few cases. So this is a 72-year-old female, and this is her EKG on telemetry, okay? So this is, we see about 6 beats of about 8 or 9 beats of rhythm. Looks like probably in the 100, almost 100 beats per minute or close to 100 beats per minute. So what's this rhythm, right? Do we see any P waves? I'm not sure. If I would look at these alone, I would say this patient may be in junctional rhythm, okay? Because there's narrow Keras complex, right? There's nice, beautiful T wave. And I don't see any clear P waves here. I don't see any clear P waves here, right? So if I look at this rhythm alone, or these 8 beats alone, I would say maybe the patient is in junctional rhythm, because narrow Keras complex, so it's not wide, it's not ventricular rhythm. So it's, but there's no P wave, so we simply call it junctional rhythm, right? But again, remember the concept of searching for the P wave. So if you do more looking, if you go back a few beats here, if you look more and look at the T wave change, so look at just at the T wave morphology, how it's changed. The T wave start having something here, something more prominent here. You see it there, you see it there. So that's your P wave. So this patient, in fact, has sinus rhythm or sinus tachycardia, whatever you call it. But the patient has a long PR interval for whatever reason. The patient has first-degree conduction delay. And when you get faster, the PR interval cannot be squeezed. This patient's disease in the AV node or whatever make him cannot squeeze or shorten the PR interval. What happened? The P wave has no space to go except backwards. It climbs slightly until it starts to be hidden on the T wave. So for example, maybe in this beat here, you see the T wave to the P is a good space here. You can tell this is T, this is P, right? And then when it gets faster, patient gets faster, the P wave start going back, and the distance between the TP segment starts shorter and shorter until here, and then now the P wave is completely hidden in the T wave. And you can tell the P wave here, the T wave here is much spikier, it's very spiky compared to the T wave here, right? So pay attention to the T wave. T wave morphology change, it may tell you that there's some atrial activity hidden there, okay? So this applies to the concept of search for the P wave carefully. The P wave can be hidden everywhere. It can be in the Keras complex, in which case it may be impossible to see it. It can be hidden in the ST segment or in the T wave, or here, that's a usual space where it should be, okay? Because there's no ventricular activity, no depolarization, no repolarization in this T Keras complex segment. So look carefully for the P wave where it's hidden, okay? Let me go to the next slide. So this is a 79-year-old male with history of coronary artery disease.
سامحني في المقاطعة. ممكن في الاي كي جي السابقة مش ناخذوا الاوبينيون بتاع الاكسبرت بانل تعليقهم، لأنه ممكن ما نقدروش نرجعوا باكورد at the end of the session for each EKG.
Sure.
مش عارف من موجود دكتور يوسف ضراط لو موجود معنا ممكن يعطينا tips and tricks finding the P wave and the morphology of the T wave from your perspective, دكتور يوسف.
أكيد. السلام عليكم. صوفيا.
واضح.
Yes, نسمع.
أنت أعطتني أصعب تلمتري يا منصور. أصعب تلمتري. السلام عليكم. بارك الله فيك دكتور فتحي على التيبس اند تريكس. بالنسبة لي الواحد هذه تلمتري. What I'm seeing يعني positive P waves في طبعا it's hard to tell which lead هذا, like I assume it looks like lead 2 morphology wise. positive P wave with gradual increase يعني في heart rate. So it's most likely a sinus tachycardia في gradual prolongation في PR interval, which is expected لأن ال AV node is decremental. كل ما يزيد الهارت rate the PR interval يزيد. If I look at this, I would say this is the sinus tachycardia with a gradual increase in the heart rate. الآن طبعاً هي I don't see the ending, how it ends. How it ends يعني could also give us a clue if it's truly sinus tachycardia versus a tachycardia, and that's the second differential diagnosis. That's a P wave 1-to-1 relation. Most likely sinus tachycardia. Second differential diagnosis is tachycardia. It's always good to see how the arrhythmia starts and how it ends. يعني. أو in between, يعني, if there's any change in the A to B relation, always gives you a clue للأريثميا يعني. But that's my input على هذه يعني. حاجة بتضيفها دكتور فتحي؟
Exactly. Shukran, Yusuf. Yeah, exactly. And if you look here, I mean, you see the sinus beat. So this is maybe a PR interval. You see beautiful P wave here. So the PR interval. So the baseline of this patient has a long PR interval. But like you said, when it starts going faster, the TP interval gets shorter. Now you might argue this could be an atrial tachycardia. There's some difference, minor morphology in there, and P wave between this and this. It's hard to tell, but again, you need more than one lead. This lead here, if you have only one lead, it gets harder, right? Because in this lead here, you may not be able to tell where the P wave, but you see that different than the T wave morphology between this T wave maybe and this T wave. So there's minor subtle change in the T wave morphology. And if this patient goes in tachycardia for long, and you have a curious, you have a 12 lead EKG only of this part here, maybe impossible to tell whether this is a junctional tachycardia, atrial tachycardia, or something. So the main concept is to just show the here is just to show that the T wave, the P wave, whatever it is it ATAC, it's sinus, regardless, it can be hidden in the T waves. That's the purpose of showing this tracing.
في حاجة بنضيفها يعني the reason I mentioned tachycardia لأن the patients on telemetry عادة telemetry patients they're in bed يعني why would someone sinus tachycardia sitting down هذه الحاجة الوحيدة اللي just to broaden the differential diagnosis بتاع الواحد always consider other possibilities. الاتر tachycardia has a phenomenon بتاعت automaticity عندها warm up period وبعدين cool down. So this is something to consider يعني في the differential diagnosis. That's why I mentioned atr tachycardia as an additional possible diagnosis.
في الدكتور أيمن يبي يشارك في الحالة هذه كذلك. دكتور أيمن تعليقك.
شكرا دكتور منصور. عندي شوية ملاحظات يا ريت نسمع رأي دكتور فتحي ودكتور يوسف ودكتور خالد. إن العادة في الساينس تاكيكارديا البي ار جيت شورتن. الحالة هذه زي ما شايف إنها هي prolonged يعني جاية مور مع هذه اللونج ار بي تاكيكارديا، لكن ويمكن هابط إن تاكيكارديا would wink back إن اللي doesn't يعني fits with sinus tachycardia. لو شفت الفيرست beat ال PR interval shorter than the next beat we start getting progressively prolonged يعني ال P wave start getting hidden with the T wave. فعادة زي ما عارفين sinus tachycardia يصير enhance لل conduction ال AV node وال PR shorten. فمش عارف their input على طبعا مهم تشوف ال onset وال offset بتاع ال arrhythmia زي ما قال دكتور يوسف باش differentiate لأن عادة sinus tachycardia gradual والإيت أتاك sudden onset offset مع الورم اب والكول داون فيهم. بس حبيت ناخذ الانبوت بتاعهم على نقطة ال PR very long to me for sinus tach. شكرا.
Right. Do you want to tackle this, Yusuf, or I can answer?
هي نقطة مهمة أيمن أنت اللي قلت يعني ممتازة جدا النقطة. Good observation. هو طبعا it depends on AV nodal properties يعني مرات في patients عندهم some AV nodal conduction disease و they may not improve يعني طبعا لما يكون عندك input وعندك sinus tachycardia you expect the PR interval to shorten in relation to إن في sympathetic input ال AV node. لكن لو patient is let's say sudden onset of an arrhythmia you can have PR prolongation يعني without any sympathetic input ال AV node. But that's why حتى هي واحدة من الحاجات you consider an atr tachycardia. بس it's not an absolute rule يعني لان حتى بالساينس سايكارديا patient has some heavy nodal disease البي ار انترفال يعني هذه وانكبات فينومينا شنو؟ يعني ان البيشنت مثلا انقعمس صار زياده في الساينس نود and they prolong بعدين drop beat بعدين they regain that second beat. It doesn't mean that this is an atrial tachycardia, it's sinus. فهمتني؟ فهذا depends on the AV nodal properties, conduction properties على AV node for that particular patient. طبعا if it's a young patient you expect the sinus tachycardia there's going to be an increase in heart rate with activity. But that's my comment يعني. ما اعرف if you want something else.
Exactly. I think it's the same thing. You can tell the patient has no healthy conduction to start with, or at least his PR interval at baseline is long. So the PR interval is long. A healthy conduction system, when there is acceleration in the sinus rate, typically it's sympathetic driven. Typically, it enhances the sinus. Whatever enhances the sinus node activity also enhances the AV conduction. So that's why you see shortening PR interval when the PP interval gets faster. That's why when people run, the PR interval gets shorter, and the sinus node gets faster. Right? They happen together. But if there's anything prohibits the AV node from getting faster, the AV node's whatever conduction system is not healthy, is not intact. We don't know in this patient what it is, and then you have the sinus node gets faster, but the AV node does not respond. In fact, the PR interval here gets longer and longer. As you can see, the PR interval here is maybe longer here, and the P waves start hiding. Again, I mean, the point to show here is that if you don't see P wave here, your differential diagnosis is completely different if you look at the P wave here. So here you can say maybe junctional tachycardia, whatever. If you have a 12, you have a 12 beat EKG of 1, 2, 3 beats. If these 3 beats, the whole thing, it's impossible to tell where is the P wave, right? But when you see the P wave, and then you can tell, okay, atrial sinus tachycardia, etc. And that's beyond the scope of this case. But yeah, exactly. I like what Yusuf said for the AV node conduction.
يعني just
can we move to the next case?
Definitely.
Sorry, go ahead.
I would add just one sentence. I know it's too late getting, but just I have to add one point. My traditional teaching in my fellowship, I was told that the T wave shouldn't be pointed like spiky T wave like this one over here. It shouldn't be like a point, like pinpoint T waves. We call it tinted B wave or a spiky T wave. You always think about hidden P atrial activity in the top of the T wave over there, or pseudo R wave in lead V1 or pseudo S wave in lead 2. فهدينا hints to find the P wave compare it with the baseline EKG, pseudo S wave in lead 2, pseudo R wave in lead V1, and tinted or spiky or pointed T wave. سامحنا دكتور فتحي على التأخير، تفضل.
No problem. Thank you. So this is a 79-year-old man with history of coronary artery disease. He presented with this white crest complex tachycardia. Okay, so this is, as you can see here, it's a white crest complex tachycardia, very fast. I think the heart rate is what, 180 or so, very fast, white complex tachycardia. And in this case, if you try to, the morphology is right bundle branch block, and if you try to find, okay, where's the P wave? Try to search to look for the P wave. It may be hard to convince yourself there is specific P wave here and there. Let me just go back. Okay, well, the question is it VT or SVT with aberration or atrial flutter, or I cannot tell, need more. Okay, so 1, 2, 3, or 4. Choose one of these. Okay, as a reply to this. So VT number 1, SVT number 2, flutter 3. Cannot tell, need more information number 4, which is always an easy answer, right? So this is the rhythm. So VT number 1, SVT with right bundle block number 2, flutter number 3, and need more information number 4. Anybody you should need more information? Everybody convinced that it's T? Okay. Okay. Good. So I think people, and you can here apply the morphological criteria, whatever, etc. And or I think, like Ayman said, if somebody is old, with history of coronary artery disease, assume it's VT until proven otherwise. Okay. So in this case, in fact, this patient has an ICD, okay? And this is the tracings from the tachycardia, from the ICD during the tachycardia. Same concept we used earlier. This is an atrial channel. This is a ventricular channel. And you can tell there's a lot of V's. There's much more V's, a lot of ventricular activities. And don't look at these, like I said earlier, don't look at them as wide or narrow complex, because these are not surface EKG. This is just a near field intracardiac electrogram. So there's a lot of ventricular activities compared to the atrial activities. So atrium is slower and ventricle is faster. So definitely there is tachycardia in the ventricle. So there is a ventricular tachycardia, 100%. Now, if we try to think about the VA relationship here, you can see for each 2 ventricular beat, there is 1 atrial beat. Ventricle, ventricle, 1 atrium, ventricle, ventricle, 1 atrium, ventricle, ventricle, 1 atrium. And that's this, ventricle, ventricle, 1 atrium, ventricle, ventricle, 1 atrium. So what we have here, we have ventricular tachycardia conduct to the atrium, but here we have what we call VA block. So the ventricle block to the atrium here, but the ventricle drives the atrium here. The ventricle block to the atrium here, the ventricle drives the atrium here. So this is a rare example where you have the ventricle drives the atrium, but not for every beat, every other beat. So the ventricle conducted back to this one here most likely, and the ventricle did not conduct back to the atrium here. Ventricle conducted back, ventricle block, conduct, block, conduct, block, conduct, block, and it's very consistent. So this is not an AV dissociation, not a VA dissociation. This is a ventricle drives the atrium. So there is VA association, ventricle drives the atrium, but there is some block retrogradely. This is again diagnostic ventricular tachycardia. When you see something like this, this is diagnostic ventricular tachycardia. And now if we go back to look at the EKG of this patient here, if you take part of the rhythm strip at the bottom, so you see that lead 2 rhythm strip, if you take it, if you zoom on it, and then now if you look at the T waves, you see there's something in this T wave here, but this T wave is completely smooth and flat. You see something in the T wave here, and this T wave is completely zoom and flat. And if you correlate them, what you see here is this is retrograde P waves there. So V conducted, V blocked, V conducted, V blocked, V conducted, V blocked. So if you look carefully at the EKG sometimes, I know it's subtle hint, but again, you search for the P wave, look for very subtle changes in the T wave morphology, especially if this is seen only in one beat, not seen on the other, seen here, not seen on the other. This should trigger your thinking curiosity. Okay, well, there must be VA dissociation or VA association with retrograde block or something. And that's exactly correlate with the intracardiac electrogram. This is the same patient, but here's the patient twice. Here's one tracing, and here's the same patient at different time. When you look at the T wave here, you see here, there's something in the T wave here different than this alternating, right? So you know this P wave hide nothing, and this P wave this T wave hides nothing, and this T wave hides a P wave. Nothing, P wave, nothing, P wave. But if you look at the same tracing at the bottom here, you see there's P wave in each of these. So here there's retrograde 2-to-1 conduction, while here the ventricle drives the atrium. So there's 1-to-1 VA conduction here. When it's 1-to-1 VA conduction, it's harder to detect it, harder to make the diagnosis sometimes. This is easier to make the diagnosis, but here you don't know whether what you see here is part of the T wave, this is the actual T wave, or there is a P wave. You have no clue. You cannot tell without having an intracardiac electrogram. So in this patient, just go back. And this patient has a, if you go a second, here you can look at the rhythm strip here. So the patient was in tachycardia. The ICD paced the patient out of the tachycardia and terminated the tachycardia. So here's the termination of the tachycardia, and the patient started having some paced beat after that. So VT with 2-to-1 VA conduction, and then VT with 1-to-1 VA conduction, anti-tachycardia pacing by the ICD terminated and the patient in sinus rhythm. But again, the whole purpose of this is not the ICD itself. The whole purpose of this case is to show you that you need to look carefully for what the P wave can look like. So the scope of this case is just beyond the ICD interrogation or something. Okay, and okay, so the next case is this one here. So this is a 56-year-old male with history of palpitation. So what's the diagnosis here? So we have few answers. Is it AF with RVR or AV node or entry tachycardia? Number 2. Number 3, AFib/flutter. Number 4, cannot tell, need more information. So this one here. Whoever votes for AFib, just put number 1. AV node or re-entry tachycardia, put number 2. AFib/flutter. I love that term. Some people use it, AFib flutter. That's number 3, or need more information, number 4. So just type something in the chat box. One, 2, 3, or 4. Okay. Looks like no answers. Okay, so we'll move on. So if you look at the tracings of this patient here with another EKG here, you can see there's clearly a P wave here, right? And if you go back, same thing, if you go back and look at those T wave changes here, if you look at this part here, so if you take this part and make it big, and then you can tell that there is the change in the morphology. So this is a sinus beat, no question about it, right? But there's something here in the T wave ST segment. There's something here that's most likely probably a P wave, and there's probably a P wave here, probably a P wave here, a P wave, and you can see the shape of the P wave of the T wave changes. Here, this is the spiky P wave Mansour was talking about it, which is the spiky, very spiky. So most likely there's a P wave here started the whole thing. So if you look at these, all these are P wave. So what we have here, we have sinus beats, and then we have a run of most likely atrial tachycardia, sudden onset, most likely. So sinus tachycardia would conduct. So A drives V, but you have slowly, the PR interval gets slowly longer, and the P wave now start falling back on the ascending limb of the T wave, and maybe even here, as the PR interval gets longer for the winky back. So atrial tachycardia would winky back. The last beat was, the last P wave was this one here. This is blocked. This does not drive the ventricle. This is blocked right there. So you have a winky back. You have 1, 2, 3, 4, 5, 6, 7, 8, 8 atrial beats with 7 ventricular beats. So you have 7 to 8 atrial winky back for this run of atrial tachycardia. After the atrial tachycardia terminated here, sinus node started, or sinus rhythm started again. So this is a much clearer example regarding the issue we have a discussion earlier about it. Same thing, you search for the P wave carefully. This time it's hidden in this part of and there's a blocked P wave to the atrium. So this was not actually AFib. You need to look carefully and the T wave and ST segment, like I said earlier. So this is the same patient. They give the patient some cardiazam in the drip, okay? So they give him an ICU, give him cardiazam. And now with the cardiazam, you can tell there's the PR interval gets longer. You see there's fluctuations, and you see this P wave hidden there. There is P wave hidden there. There's P wave hidden there. There's P wave hidden there. And then what you do next is just to confirm the diagnosis, you just do carotid sinus massage. So you go and do CSM, or you can give adenosine. And clearly after you did the adenosine, you see this P wave was hidden there, P wave here, P wave hidden there. And after you do carotid sinus massage, you confirm that the atrium is going in some sort of atrial tachycardia, has nothing, or flutter, has nothing to do with the ventricle. So this is an example of using more things to clarify the relationship between the atrium and the ventricle, carotid sinus massage, for example. Next, case is what was given to EF instead of what to give patient low EF. Yeah, if you're a good question. So if you're not sure, you can give adenosine to confirm. But carotid sinus massage, I still prefer that technique. It's simple. Unfortunately, it's maybe under taught, but if you do it, maybe another setting, we can talk about how to do proper carotid sinus massage. But if somebody is low EF, you don't want to give cardizem, you can give adenosine to delineate that. This is another case. This is a 75-year-old female. She had a history of pacemaker. She was having routine EKG in the office, and she had this EKG done. And the question is, what's the underlying rhythm? Okay, so is this answer one, paced rhythm? Number two, sinus rhythm with bundle branch block. Number three, cannot tell, need more information. So you can use one of these things, 1, 2, or 3. Okay, sinus with bundle branch block, or paced rhythm, or cannot tell. So 1, 2, or 3. Okay, we're gonna go back to the EKG. Just type either 1, 2, or 3. So 1, yeah, paced rhythm. Yeah, clearly you see some pacemaker here, right? Some pacemaker spikes here. And then sinus, anybody? So remember, when we say paced rhythm, you're talking about the ventricle, right? But always the question is what's happening in the atrium. You need to ask what's happening in the atrium, which is so important. So here you can tell there's some atrial activity if you look at lead 2, right? Some atrial activity, but is this sinus? What's this? Is this a T wave or part of the U or whatever? So sometimes it's hard to determine, right? Well, this is sinus flutter, whatever. And in these cases, you need to amplify things. So this EKG was done on a 12 millimeter per millivolt amplification. And you see this box here. So this is a box for 10. What you need to do, repeat the EKG with 20 millivolts. So you just go higher millivoltage, and sometimes that will clarify the diagnosis for you. So now the patient is not paced as much, so the patient is intermittently paced. But more important here, you can see that the atrium is in a flutter, right? And the way to do that is by amplifying the baseline, the EKG baseline. So instead of 10 millivolt, you do a 20 millivolt. Very simple thing you can do in the office. And when you know that the patient is in flutter, now the treatment will involve other things like, does the patient need to be having to be put in anticoagulation, et cetera, et cetera. So being paced rhythm alone, that talks about the ventricle. So always think about the atrium. If you don't see the atrium clearly, do more techniques, either do carotid sinus massage, like we said in this case, or you can do the double voltage EKG, okay? So these are, or adenosine. So these are a few maneuvers you can do to delineate what's the atrium is doing. This is another patient, 76, history of coronary artery disease. He was seen in the ER for a routine, I think a cold-like symptoms or whatever. And this is his EKG in the ER. His heart rate was 120 beats per minute, okay? And this was his EKG in the ER. And the question is again, what's the rhythm, okay? So I'll give you a few examples, few answers. So is this flutter with variable AV conduction? Or this is intermittent Wolff-Parkinson-White or intermittent pre-excitation, or this is VT, or this is sinus rhythm with winky back, okay? So these are the 4 answers: flutter, variable conduction, intermittent pre-excitation, VT, or sinus with winky back. We'll go back one look here, and we'll give about 20 seconds for people to point 1, 2, 3, or 4. 1 is flutter with variable AV conduction, 2 intermittent pre-excitation, 3 VT, 4 sinus with winky back. Okay. 2, 3. Wolff-Parkinson-White. Okay. So yeah, flutter is number 1. Okay, flutter. Number 2, intermittent Wolff-Parkinson-White. Number 3, VT. Okay, and number 4, sinus with winky back. Okay. So this is, although the patient is hemodynamically stable, This is ventricular tachycardia, okay? And again, if you look and carefully search for P waves, you can tell that there's an atrial activity here, there's an atrial activity here, there's an atrial activity here. And then when you find some, like I said, lead V1 is a nice lead because it's a treasure box. There is a lot of, it's the best way sometimes to find the P waves. So if you find P waves here, go to the rhythm strip and try to search for any P waves hidden in the rhythm strip. And this is pretty much easy case because there you can see the P wave here, you can see here. So there must be a P wave in the middle. So take your caliber or take a piece of paper and start to point at P wave here, P wave here. Okay, so the next one is going to be here. And then if you take the same distance from here to here visually, the next one is going to be here. Visually take the same distance. So this is going to be a P wave. Visually take another distance, it's going to be a P wave. But the Kearse complex now is narrow. So this means this is probably sinus beats. It's narrow Kearse complex. You look at here, the P wave, there's a P wave, short PR interval, and the beat is narrow. So this is probably what we call it a capture beat. If you go back, this is a P wave there. At the same distance, you take the same distance back, there's a P wave here, same distance back, P wave here. So the P wave is going at a rate of maybe 70, 80 beats per minute. You see the PP interval is fixed and is unrelated, but every now and then the P wave captures the ventricle. If you look at the tachycardia, this is maybe full beat of tachycardia. Probably this is the VT. The VT is not affected by the Kearse complex. But every now and then you see a beat like this one here. It's not as narrow as the capture beat and is not as wide as the tachycardia beat. So this one is in the middle. So we call that fusion beat, okay? So this is you can have a better EKG than this for what we call, you can have AV dissociation or you can have fusion beats where the tachycardia fires and the sinus fires, and you can have a beat in between like this one here. So this patient has tachycardia like this wide. Every now and then you can have a fusion beat between the tachycardia and sinus beat, or every now and then you have a sinus beat. It's completely sinus beat. So everybody's familiar with this concept. So if you go back to the EKG of that patient, you can tell that there's the red arrows. These are the sinus beats. They go in independent of the faster Kearse complexes, and there's every now and then there's a change in the morphology of Kearse complex by either capture beats or by fusion beats. So this is classical, very classical ventricular tachycardia with all the AV dissociation criteria and features. Now the heart rate is not super fast. Ventricular tachycardia doesn't need to be too fast. The patient may be hemodynamically stable. In fact, this patient was just seen in the ER for other reason and related to the tachycardia. But again, you'd be surprised how many patients can walk with ventricular tachycardia. Again, apply the same thing. What's the ventricle is doing, what the atrium is doing, and if there's any relationship between both of them. So this is a capture beat, this is a fusion beat. And if you see this capture beat, fusion beat, or VA dissociation, etc., this can all be pathognomonic for ventricular tachycardia. Now, another thing, this is a 76-year-old male with coronary artery disease and history of palpitations. So this is the EKG. And then if you look at here, the patient has 1, 2, 3, 4, maybe 8 rhythm or 6 leads. And the most attractive part of this EKG is here. You know, your eye leaves this and your eye gets jump on this and say, wow, there's something going on here, right? And this here, you can tell, it looks like VT. I mean, I think the question we have for this patient, give normal sinus rhythm, do nothing, or IV, give Coumadin, or non-sustained ventricular tachycardia, get an echo, or Torsade de Pointes and give magnesium, right? And of course, okay, some people think give magnesium, Torsade, okay. Okay, so if we go back, okay, yeah, so beautiful. So we think it's Torsade, you give magnesium, okay, so that's good thinking. We think it's Torsade because what we're looking at the morphology change. You get bigger, get smaller, but again, don't let this fool you. Whatever you see a noise like this, look for 2 things. Look for, is any P wave hidden or Kearse complex are hidden within other things. Now we have, if you look carefully here, there's a sharp beat here, a sharp beat here, and all other are just artifact. These are If you take the rhythm again, if you look at the blue lines, if you take a caliber and move, just take a piece of paper and pen and then go. So you see this sharp thing here, you see it here. This is exactly at the same timing between this, and the same here, and you see it there. All the other things you see, these are muscle artifact from the small, because the EKG on the surface chest wall, right? It picks up skeletal muscle. So this is, but the same, you see it more clear here. So actually some leads, you see it more easier. So the blunt shape, these ones here, these are artifact, extra cardiac activity. These are all, could be a loose lead, could be muscle artifact, could be anything. But the cardiac activity is still the same. It's unaffected, the timing is the same. And if you, of course, I have hidden this lead here. This is a 12 lead EKG patient. I hide this intentionally because sometimes all you see in the hospital is one lead. Sometimes all you see this lead here. If you see the whole, all the three leads together, it's easy, right? Because you know, this is, if it's torsade here, why it's not torsade here, right? So you know there is issue with these two leads, and that's why I give you the artifact here. But this is simultaneity. So the rhythm uninterrupted, this is clearly artifact. This is pretty common, very, very common. And there's also some publications about this. So I want you to be aware of this. The artifact can trick you. So the key thing is to look for more leads, more than just this or this, because it can be easier in some leads than the others. Here's no artifact, here's some artifact, here's more prominent artifact. So it's harder to detect the normal sinus rhythm here. And also look for the sharp, spiky beats in the midst of this blunty beats, okay? So that's a pretty common rhythm, we see it all the time. So be careful of artifact, okay? This is another case. This is a 54-year-old female with multivessel disease. She had cath, positive for multivessel disease, and look at this. I think if a lot of people, if they look at this, they will get, typically the ER, etc., they will call for your cardiology consult or something. But again, this is just an artifact. If you look carefully here, this is sinus, and then there's spiky thing here, that's a sinus, that's other sinus, the other sinus beat is here, or yeah, these are the Kearse complex, this is the other Kearse complex, this is this sharpie thing, Kearse complex. This is beautiful because you can see here the blunty and the sharpie over it. This is the same thing, this is a sharpie of the blunty. All you need to do is just stick a piece of paper and mark here, and just move backwards, and it will show you exactly where is every one of these. And again, another one here. So I'm sure most of our cardiologists in the audience, they will see this maybe at least once or twice a month, those artifacts. But you need to go after, look at more leads, think about the sharpie stuff. Here's a nice sharpie thing in the midst of a blunty stuff. Okay, so that's an artifact. Just go forwards. So tip number 4: look for artifacts and beware of and look for different leads, like we said. We'll move on. This is a
ناخذ الاوبينيون مع دكتور خالد بوزقية مش يشارك معنا كذلك في الاكسبرت بانل. دكتور خالد تحب تضيف اي اضافه بالنسبه للارتيفاكت tips and tricks or any comments so far from what was given earlier in the lecture?
You know what, Yusuf, yeah, Mansour, I would love Khalid Bouzguia's input about this coming case here. Should we? Okay, yeah. والله لا يا خالد. If you want to go by the artifact, you go ahead.
لا خلي في الكيس دي يا فتحي.
Yeah, في الكيس دي, yeah, I think so. Yeah, so this is a 23-year-old male presented with palpitations, and he has this Kearse complex tachycardia. Okay, so this patient is young, and he have what looks like fast tachycardia. When he presented, the heart rate was close to 200. And then right bundle branch block. This is from many years ago, but I love this case because it's very informative. So he came to the ER. I give people a minute here to look at the tachycardia. So this patient has a tachycardia for 4 hours. He has palpitation for 4 years, on and off. He had flu-like symptoms 3 weeks earlier. In the ER, they gave him adenosine, 6 milligrams, 12 milligrams, 12 milligrams, no effect. And then they put him on a cardiogram drip. On the cardiac drip, the rate slowed a little bit, became a little slower. Like I think went from like 200, 190, 200 to 180, 170 beats per minute, but tachycardia did not terminate. The patient is very stable and he feels okay. All right. So this is the clinical scenario for this case. You just go back to the 12 lead EKG, and people, people can just type in the chat box, what do you think? SVT, VT, cannot tell. SVT, VT, or cannot tell, maybe one of the three. We'll start by SVT, VT, cannot tell, just 1, 2, or 3. We don't have a question slide for this, but just go ahead, SVT, okay. VT or cannot tell, SVT. And looks like a beautiful typical right bundle morphology. Okay, so I've seen 3 SVTs. I'm a little bit disappointed. I wanted people say cannot tell. Would be nice to get. There's nothing wrong with answering cannot tell, but SVT, I mean, and VT, these are the 3 things. Okay. All right. Just go back to this. So here, I don't know, Khalid, do you want to come in now, or you want to me go through the case and then you review the whole case afterwards? Khalid, are you there? Can you hear me? Mansour, can you hear me?
نسمع فيك
Okay.
ممتاز فتحي. لا فعلا هو tricky
Okay.
case. Could be either, in my opinion, حتى تكون typical right bundle. Sometimes you have vesicular VT in young people. Sometimes it's hard, but anyhow, we would love to hear from you.
Okay.
يعني
Good.
some of the T waves are spiky. I'm not sure how accurate it is, but some of the T waves look at different morphology at the beginning, at the end. But let us see. Let the case reveal.
Okay, sounds good. Okay, so this is narcosis complex tachycardia, the differential again SVT, VT, with aberration or VT or vesicular tachycardia, like you elaborated, and then this patient was given adenosine, 3 doses, no effect. They put in a cardizem drip. So here's what I recommend. So if you look the case and look at the timer, so these are the rhythm strip taken from the patient, okay? And when you look at the rhythm strip from the patient, is going very fast. This is lead 2 and this is lead V1, or equivalent. This is equivalent to lead 2 and this equivalent to lead V1. And every now and then you see something like this. Every now and then you see something like this. You see something like this. You see something like this. So whenever you see, things like this, it should provoke your thinking, okay, are we seeing some atrial activity? And if these are atrial activities, if this is a P wave, and this is a P wave, and then there may be a faster, ventricular rates than the atrial rate, right? So if this is a P wave and this is a P wave, and this has to be ventricular tachycardia, or likely to be ventricular tachycardia, right? So that's something you need to think of. And then later on, this is after the cardizem. Now the patient is on a cardizem drip, okay? So they gave him cardizem. Tachycardia is slower. This is only 1 lead. Remember, we don't have both leads now. The tachycardia is slower, but every now and then you see some sort of a P wave, something suspicious for a P wave hidden there. So now you can see a lot of ventricular and few atrial activities. So when you see something like this, it should provoke your thinking, okay, well, let me go basic. Is the atrium drive the ventricle drive the atrium, or no dissociation? here we clearly see an atrium and ventricle. They're not necessarily correlated to each other, right? And this should be simply make you think it could be ventricular tachycardia. So just what the teaching point here is this. And this one here, it's maybe impossible to tell. I cannot tell you it's SVT. I'm sorry for something. And this one here is impossible to tell. It's SVT or a fascicular VT, which is, you know, unique tachycardia happen in younger people, where the patient have a right bone branch block morphology and left superior axis, which this patient has. And so this could be ventricular tachycardia, one of the rare ventricular tachycardias. But the question is this related to that, or this is supraventricular tachycardia? How to tell? So in this case alone, I think it makes you suspicious, but you need to do more search. So what we did in that case, we went to the telemetry rhythm strip, and I recommend everybody, a cardiologist, especially those who deal with the rhythm, they know this, but a general cardiologist, just go and look at rhythm strip, spend more time in the rhythm strip, because you learn a lot, you find more information. And here you start to see the clues. The clues would be these little things, you see them here and there. For example, this one is more beautiful. Why this is seen here and not seen here? Clearly there's something going on here. And this is most likely, the heart has two major territory, atrium and ventricle. If the ventricle is this must be an atrium. Same thing happens here. This must be an atrium. We don't see it here. This beautiful, very clean part of the ST repolarization. So this must be a true atrial activity. This must be true atrial activity. And that should trigger your, you know, curiosity to search more and do more. So this is like shortly after they gave the cardizem. And after they gave the cardizem, the tachycardia slowed a little bit, but you can see more of the atrial activity. So what people would do next now? Any question, any comments? I need people enter. So what would you do now here? Would you give cardiogenic shock? Would you do cardioversion? Would you try different medicine? Would you try adenosine, higher dose cardizem? I want some input here. Verapamil, nice. Okay, so everybody thinks verapamil beautiful. So here's after verapamil was given. So here, verapamil was given, and then boom, 5 minutes after verapamil was given, tachycardia terminated. You can see this is now 1701. Okay, so after 5 minutes, verapamil was given, tachycardia terminated. But what you notice now, the patient has a sinus rhythm, but you see now long PR interval. It's almost like a very long PR interval. You see this? So so this tachycardia terminated. The patient has a long PR interval, which is maybe Mansour can control the audios, the participants' videos and stuff. So tachycardia terminated with long PR interval. And the reason for this long PR interval is most likely the large dose of cardizem the patient was put on. Okay, so this is probably not a pathological. But again, Ayman, this is an example of patient who have probably healthy conduction system, but when you hit it with a large dose of calcium channel blocker, 2 calcium channel blocker IV, you can see, I'm sorry, just gonna go back to this here to show. It gives you a long PR interval at baseline. You see this? So this is an example of that. And here you can see that there's a P wave more clearly here. So let me give you all the time scale of this patient. So this patient, when presented this, okay, let me explain this to you here. This is the time at the bottom, and this is the heart rate. This is 0 heart rate, 50, 100, 150, 200 beats per minute, okay? And the heart rate, 85 beats per minute here is at that time here. See where their little triangle there? So heart rate here was 85 beats per minute, between 50 and 100, okay? But let's go back to when the patient presented. When the patient presented, had a heart rate close to 200 beats per minute. They gave him adenosine stuff, nothing happened. At this time here, from, I don't know, 15, 30, whatever, until this time here, the patient was on the cardizem drip. And you can see the cardizem drop the heart rates, but it's still 170, 180. If this is 150 line, the heart rate was in the 170, 180. Only after verapamil was given, you can see dramatic drop in the heart rate, and then initially was slow and then recovered slightly after they stopped because we stopped the cardiogram immediately after that. The diagnosis was clear, and this is the patient's EKG after the after conversion. So you can see sinus beat here, and then go some baseline winky back. So this is a patient having P wave and longer PR interval, patient having a winky back at baseline, and then this P wave here dropped. So this is an example when you have a iatrogenic pathology in the AV nodal conduction system, like a lot of those of intravenous calcium channel blocker. You can see the P wave behaves in the typical decremental conduction, and this blocks here. So this is a nice winky back cycle, but that's not pathological. This is just because we gave the patient a lot of calcium channel blockers in a short period of time. And back to this diagram here, because this shows you the time frame. This shows you how verapamil is so impactful in converting this tachycardia. Okay, so I'm just gonna go quick slides here. It's beyond the scope of this presentation, but for my EP colleagues in the group here. So patient was taken to the EP lab, and these tracings are induced in the EP lab. Here, simple, just if you pay attention to maybe the bottom part here would say his here. So you see patient was running a ventricular tachycardia. This is the surface EKG lead 1, 2, and V1. These are tachycardia, so the patient was going fast. So the patient was in tachycardia. This is HRA, means high rate atrium. So this is the atrium, and you can see the ventricle is much faster than the atrium, and the atrium is slower, and the atrium appears to be dissociated from the ventricle. You see here, the atrium and the ventricle happen at the same time. Here, the atrium happened slightly after the ventricle, and here the atrium happened later after the atrium, and here the atrium happened later. So this is the EKGs where we were seeing some P wave hidden there and here, and when we went to look at the telemetry strips. So you see, sorry, just for some reason I'm not in control of this PowerPoint. So the reason here, if when you see, so the P wave sometimes on the surface EKG, in this case, you can see a P wave here, but you may not see this P wave, you may not see this P wave, you may not see this P wave. So this one here is exactly in the surface EKG as, for example, this one here, maybe this one here, or this one here, or this one here. So you see them sporadically every now and then, but this is intracardiac tracing, so this is confirmed. This is to be a ventricular tachycardia, and this is where we have here the same thing. This is a much faster speed. Sweep speed is about 100 here, and then this is the ablation catheter here, and the ablation catheter, for the distal ablation catheter, you have the tachycardia start with some potentials before the surface. So this is tachycardia on the spot on the posterior fascicle. You started here before the surface EKG. So if you measure time from here to here is way faster, so you know you're ahead of the tachycardia, and then you ablate the tachycardia terminated, and this tells you that this is the ablation catheter. The location of the ablation catheter here. This is his electricity. This is his bundle, and you have the signals of the posterior fascicle here on after the ablation. So it shows you successful. You're on the posterior fascicle. You see the intracardiac electrocardiogram, and then you test the conduction, and the conduction is quite healthy at the end. These are beyond the scope. These are just for my EP friends here in the group to enjoy these.
I think you did a great explanation, and there's nothing to add. يعني على الحالة هذه يعني واضح. يعني أنت you explained its vesicular VT. بس عندي سؤال practical question. احنا طبعا نعرف البيشنتس اللي عندهم VT they meet an indication for secondary prevention for ICD implantation. سؤالي my colleagues يعني الكارديولوجيست والinternal medicine doctors is there an indication for ICD in this patient؟ يعني هل تبعت الكارديولوجيست او للاي بي باش يندير له ICD this patient؟ يعني هذا هو سؤالي، فنشوف الاجابات يعني، بس would like to know if
yes
you
or
would
no.
recommend
Great
an
question,
ICD.
Yusuf.
Yeah, yes or no.
Yes, great question, Yusuf. Very nice. Yes or no. ICD, yes. No ICD, no. Please type it here in the ICD. ICD or no ICD? Okay, ICD, yes. Okay, we have 1 yes. 2 yes. 3 yes. Wow. Okay, go ahead, Yusuf. Give the answer, please.
طبعا ال 10% of VTs are idiopathic VTs، يعني اللي هم ال VT اللي هم يعني generally benign، they're not associated with sudden cardiac death. ومنهم الفاسيكولار VT، يعني الفاسيكولار VT it's unlikely to cause sudden cardiac death. يعني those patients، يعني what I would do is get an echo. If the ejection fraction is completely normal, especially in a young patient، أو cardiac MRI، هو cardiac MRI موجود في ليبيا، there's no indication from ICD. لأن this is an idiopathic VT سوى left bundle branch morphology ولا outflow tract VT أو الفاسيكولار VT they are generally benign. treatment اللي هو الكارديزم في الحالة زي هذه وفيراباميل والابليشن، definitely ablation is an excellent treatment للحالات هذه، بس ICD is not indicated in this case.
I agree. Thank you, Yusuf. The great point. I completely missed my attention. And in fact, this patient has both echo and MRI, and both were normal. And this patient and this patient underwent just this ablation procedure, and we saw him 2 years later. He was doing fine. He works in the cables, like he goes high towers and like very high towers. He works with a company called AT&T for connection cables, and his job is quite risky. And we didn't give him ICD. Yeah, there was a classical idiopathic VT that was ablated. Great point, Yusuf. Khalid, I mean, can you please give us your input and comments, especially about the EKG, please?
About this EKG or any prior EKGs so far?
Whatever, Khalid. I mean, I think if you want to add to this case or prior, because we have one more last case and we'll be done.
Yeah, بس التايم لأن تو الآن an hour and a half. I think we should focus on this. There is no time left. Maybe we'll give last 15-20 minutes to discussion. Dr. Khalid Bouzguiya, I hope that you are available with us. Yeah.
نعم. Fathi, as usual, great presentation from the master of EKG. A few points, I think, very practical point. I think when I started training, Fathi, the P wave was a forgotten element in the EKG. And I remember recently we were attending a conference with Dr. George Klein and say that recently he's been seeing more mistakes by people imagining P waves. So while it's very important to look for the P wave, but I think we went to some extreme. Sometimes we imagine P wave. I think for me, instead of trying to imagine this is what P wave, you should try to prove this is a P wave. That's my tip number one. And that, Fathi, I think you covered that by maybe giving adenosine, carotid massage, giving some AV node blockade, or sometimes even doing different type of EKG like Lewis lead or something like that. So that's my tip number one is, yes, look for the P wave, but don't overlook the P wave. Sometimes you may think this is P wave and it's not. Second thing is, it's very important to compare. We always think about the P wave, but we forgot about the morphology of the P wave. So it's very important to always look for the EKG, resting EKG, and to compare the sinus P wave morphology with what we think P wave morphology. Another tip I want to highlight is it's very confusing to say AV dissociations. Does this means 1-to-1, 1-to-2, or there is no association at all? And with VT, you may have retrograde conduction, but you may also have sinus node marching through, and you still have VT, and they are completely dissociated. So the other thing is, it's very easy for especially junior doctors with us in the group. Whenever you see a broad QRS, whether is it tachycardia or not, there is only 6 possibilities, and try to work through it one by one. It will make your life a lot easier. Is this VT? Is this some form of SVT with aberrancy? Is this pre-excited rhythm? These are the top 3. Then the last 3, which are easy to rule out, is this paced rhythm? Is this artifact? Or is there electrolyte imbalance? There is nothing else out of these 6 categories will give you a broad QRS. So if you try to have a systematic approach when you see an EKG, this will help you sort out the differential of VT. Now, a tip to you all that even senior electrophysiologists like Dr. Idris will find it difficult to differentiate between the different type of tachycardia. We could never get it right. However, if you're not sure, always treat any broad complex tachy as a VT. I think that's the teaching point. Now, all algorithms, we know that Fathi and Yusuf, like Brugada algorithm, AVR algorithms, all algorithm has shortfalls. Nothing is perfect. So you always have to use your clinical judgment. We don't treat EKG, we treat patients. So take patient context into your assessment and make the right decision. Remember to compare your EKG with the resting EKG. Artifact, Fathi, your case, a very interesting case, artifact, because usually you will see the artifacts in the limb lead, not in the chest lead. And my tip, whenever you see something like that, some modern EKG machine, you could go back and do a rhythm strip. But the hint, usually, if you have something look like a torsad or VT, and the patient is eating their breakfast, then it's unlikely to be a torsad or VF, because they're not going to be well. But I agree with you, artifact, you need to look at the QRS, whether is it marching through, and it tend to be more the limb lead rather than the chest lead, but it could be, as in your example, it could be any lead. In your last case, interestingly, the fascicular VT is a typical example of a VT which break all the rules for VT versus SVT with aberrancy differentiations. It looks like a bundle branch morphology. It terminates with verapamil. Most patients are not hemodynamically compromised. The QRS is not broad. The nadir to S duration is very narrow. Again, fascicular VT, whenever you see a young patient with normal heart, and I think this is what Yusuf's point is very important. Normal heart VT is benign. Usually they do very well with medical therapy or ablation, and most of them, if they don't have if they have a normal LV, they don't need an ICD. I think this is my summary in tip and tricks, but I think Fathi did an excellent job, and I'll be open to any questions.
دكتور يوسف الضرات, لو عندك أي إضافة regarding any prior EKGs.
بارك الله فيكم, محاضرة ممتازة طبعا. زي ما قال خالد ماستر في EKGs, ما شاء الله عليه دكتور فتحي. وخالد انت you summarized really well. يعني أنا بس الحاجة الوحيدة بس يعني هو السمري اللي قالوه الاثنين. يعني I think how to approach an EKG ولا intracardiac. I think احنا ال EPs we think in a different way. We think of the يعني ال A wave بروحها, ال ventricle بروحها, وال AV node بروحها. يعني how many P waves do you have? يعني if you look at an EKG, that's هذه الحاجة الحين متاحة لنا نشوفوها عادة when we first see the patient. حاول طبعا we always see the ventricle. لازم او اللي هي ال QRS complex ventricular beat, لازم نحاول ندوروا على ال P waves to see الريليشن بين البي. يعني treat البي ويف او الاتريوم as a separate chamber. شنو هي الالكتريكال اكتيفيتي موجوده في الاتريوم, شنو هي الالكتريكال اكتيفيتي موجوده في الفنتريكل, then try to correlate, حاول تربط ما بينهم الدوز. فهمتني؟ فهذا مجرد توضيح او different approach للاريثميا. هذه يجيب نقطة مهمة أعتقد دكتور فتحي تقريبا بكري ذكرت على الأدينوسين. الأدينوسين is really important. يعني لو عندك narrow complex tachycardia, don't hesitate to use adenosine. And adenosine is going to block the AV node and it's going to show you شنو صاير في الاتريوم, شنو الريليشن بين الاتريوم والفنتريكل. If you use intravenous adenosine, this could be an AV nodal dependent arrhythmia زي ال AVNRT أو ال AVRT versus atrial flutter مثلا. ف always think لما تشرح ال EKG atrium ventricle والAV node كseparate entities أو mechanisms involved في الأريثميا. بارك الله فيكم. شكرا منصور على الفرصة وشكرا فتحي وخالد.
لا مبسوطين جدا والله يعني very excited today. I did learn a lot honestly so far. دكتور فتحي ممكن ما علقتش على إجابة السؤال هذا ممكن تعلق عليها قبل.
Yeah, شكرا. Yeah, thank you. I'm sorry it took long. وشكرا طبعا خالد ويوسف من كمكم. This is just a nice to hear everybody's input. We completely agree with all the comments. So just before we finish, let's go back to this very first case we started. Remember, this is a 43-year-old female with history of a shock by her ICD, okay? So the question is this, we asked this question before, is this patient in sinus rhythm? Yes, no, or maybe. So if you think it's in sinus rhythm, you're sure, say yes. If you think this patient is not in sinus rhythm, number 2, or this patient may be in sinus rhythm, number 3. So I don't know what if people want to revise the question now after the first answer. I think when we started, there was some answers 1, some answers 2. So I think the point here, what you see here, this EKG, so this is the EKG alone of the ventricle, or not the EKG, this is the intracardiac electrogram from the ventricle. But if you take the intracardiac electrogram fully, if you take the full picture, you can tell that this patient, the atrium was in sinus, but the ventricle in V-fib. So I thought this is just a good illustration for people to think about the 2 chambers. So even if the whole activity is the biggest, the most important, the clinically relevant activity is the patient in VF, like in this case, this is almost like a surface EKG. It's a far field tracing. This is intracardiac tracings. So although the patient is in ventricular tachycardia in the ventricle, always think what's happening in the atrium, okay? So this is a polymorphic VT, doesn't necessarily need to be torsade. Torsade is a different diagnosis, but this is what we call polymorphic VT or VF. But think about what's the atrium. It's just try to create this mindset of what is happening in the atrium. Sometimes it's impossible to know what's happening in the atrium unless you have a lead in the atrium, like in this case, right? But you learn from handling devices. Many patients, they will have AFib and they go to VT, and when they shocked, they go to sinus rhythm. So it can be very tricky. So this patient, the answer to this one may be in sinus rhythm, because based on this tracing alone, we don't know what's happening in the atrium. So the correct answer of this one should be maybe, not yes, because we don't know. We don't see what's happening in the atrium, and you cannot say no because we don't know what's happening in the atrium. So the answer to this one is maybe. So if you get this concept, I think you probably get the morale of the whole presentation. This is after the patient was converted to sinus rhythm, and these are the few tips. I'm gonna leave them here for people just to collect them and have any questions. I'll be more than happy to answer. Thank you everybody.
أي حد ممكن يرفع إيده لو عنده أي إضافة أو سؤال للإكسبرت بانل أو دكتور فتحي. أنا دائما أقول للشباب لما يجوا يتدربوا معي الأسبوع الماضي، نقول لهم I think in the atria and ventricle are 2 separate hearts. فحاولت نوصل المعلومة هذه، ما قدرتش للأمانة، ما استوعبهاش. فسألتهم سؤال، قلت لهم لو الشخص عنده atrial fibrillation، عنده AFib، وجينا we cut the AV node from the ventricle, what will happen to the AFib? Would it terminate? Maybe yes. They said maybe. They said yes, it might not sustain if you got the AV node. So I told them simple example. If your neighbor house on fire and you get the electricity from your house from the other neighbor, and the fire is not in your house, do you think if you cut the wire, like does the fire go away just by cutting the wire between your house and your neighbor house? No, it will continue to be in fire. So both atria and both ventricle electrically connected by single wire. For both of them, they can behave the way that they like. فمعناتها مش بارت في السيركت. فلو تتخيل المعلومه بالطريقه هذه، لو انت عندك VT down in the LV ولا RV, it shouldn't be affecting what's happening in the atrium, exception with AV or VA conduction يعني. فمعنى الكلام لو تفكر فيه ما 2 separate hearts و always start with the P wave. انا دائما حتى اسال سؤال، نقول دائما which one is more important, the rhythm or the ST segment elevation. نقول في البداية دايما leaning to the interventional guys ST elevation, STEMI for example, it's emergency, but the rhythm you have some time. You can think of VT, complete heart block, sinus, but always I think the money shot for, as mentioned throughout this lecture, if you want to master the EKG, as the masters we had today in our session, is to look at the P wave. Find the P wave, you will find your money. Where is the money is where is the P wave in the heart. You find the P wave, you will find your answer. فلو في حد أي سؤال قبل ما
يا
نختم.
منصور في
أيوة.
في سؤال بس نشوف الاودينس، لان هي المين برزنتيشن كما حكى فتحي وحضرتك ويوسف، in it's very important to understand what the atrium is doing and what the ventricle is doing, وبالتالي relationship between the PP interval and the VV interval and then the AV interval. فاحنا ديما نتكلم على ال AV dissociation وال AV relation، وعادة ديما الكونسبت is لما more V than A is VT، ولما more A than V is not VT. فنبي مثلا نشوف إذا كان في أي suggestion من الأودينس يعطونا example of situation where the V more than the A was still not VT، ولا situation where the A is more than the V and it's still VT.
فممكن تكتبوا في الشات باكس يعني الإجابات. فنعطيكم 30.
This will be Mansoor very good just stimulation for what Fathi was saying. It's very important to not ignore each chamber. It doesn't mean if this chamber is doing something, the other chamber is not. So this just to see if we could come up with some differential. Let's start, Mansoor, by saying, what if there is more V's than A, but it's not VT? Do you think this is fair, Fathi? Maybe this is not fair.
So. but yeah, no, you go ahead. I think it's good to explain it. Yeah, complete.
Ventricular, premature ventricular contractions. يضل عندك V more than A.
Yeah, that's a different
خالد
thing.
اعتقد نقطة مهمة جدا اللي جبتها، يعني بصراحة يعني ممتازة جدا النقطة، يعني ممتازة جدا. يعني هو think of it يعني you can have double arrhythmias، حاجة اسمها double arrhythmia. Those arrhythmias at the same time تصير عادي، كل chamber بروحها.
Very good.
You can have a fib and VTAC, right?
ممكن تعطيهم الهنت يعني.
The best answer, as Yusuf say, you could have double tachycardia. مثلا you could still have AFib and you still have VTAC, and the AF, for example, the flutter wave is faster than the VT cycle length. So this is an example of that. You have more A than V, but you still have ventricular tachycardia. An example of if you have more V's than A, for example, sometimes هذه slightly صراحة more advanced, but you may have, for example, AV-NRT would block in the pathway. Whether
retrograde.
Yes. So if it's at the lower pathway, then you'll have A more than V. If it's at the upper pathway, you'll have more V's than A. The morale of the story is think that each chamber separately first, and then think about the link between the two. Well, the best example is dual tachycardia, atrial flutter and ventricular tachycardia. The VT could be faster than the flutter could be faster. This is just a simple example. But if you want to look into more details, there's AV-NRT and slightly more advanced stuff. But this just to highlight that it's not all about AV relationship. You need to think about each chamber separate, then link them, and then make your conclusion.
Yeah, Khalid, let me add one thing, because this is very interesting. So I think the V more than A's and A's, I see that more common in people like providers who look at intracardiac tracings. You see what I'm saying? Where especially fellows, when they start looking at pacemaker tracings, and they patient comes with a shock or something, and they try to correlate which started first, this or this. So that's because you see the atrium. Luckily for general practice, they don't see much of the atrial activities most of the time. So double tachycardia can exist and can go unrecognized. And sometimes it's not that, it doesn't change, like the case I just showed, the VT, the VF, when the ICD shocked the patient sinus rhythm, and the patient was in sinus rhythm. So sometimes it goes unrecognized, and it doesn't matter clinically. But the problem with more more V's than A's is VT, or more A's than V's is AT. That concept itself is much more common among people who look at the intracardiac electrocardiogram. You see what I'm saying? And that's where the source of confusion can be. I see it more like we're in these scenarios. However, it can be very interesting in when you have a surface EKG where you have both tachycardias at the same time, and then it becomes almost impossible for people to diagnose without having an intracardiac electrogram. Yeah, it's a very good point. Very.
اتفضل دكتور يوسف. في حد ممكن إذا كان ما فيش أي إضافة أو أي تعليق، فنحب نختم في النهاية لضيق الوقت. ففي الختام نحب نشكر جميع الحضور اللي حضورهم معنا طوال هذه المحاضرة، ونشكر الإكسبرت بانل الدكتور خالد بوزقية والدكتور يوسف الضراط، و definitely نشكر الدكتور فتحي إدريس enlightening us. We did learn a lot from you today for this lecture. وإن شاء الله نوعد الحضور this is the beginning، هذه البداية. و sometimes this one for you it's a bread and butter, و sometimes it's very hard and difficult to understand. So take your time. This lecture will be recorded, and hopefully this is the beginning. والEKG learning comes over the years with the experience and الممارسة. فما تنسوش نحب ننوه بالليبيان كاردياك سوسايتي 9th كونفرنس في مدينتنا مدينة بنغازي من 29/12 إلى 31/12. فنتمنى الجميع ممكن يشارك في الكونفرنس هذا. وفي الختام السلام عليكم ورحمة الله تعالى وبركاته.